All right, we're going to get started.
All right, hi everybody, welcome to Cycle Science. I'm excited about the turnout, so people interested in learning about the menstrual cycle. We are the tutorial of the behavioral endocrinology of the menstrual cycle. My name is Liz Bates. I'm a senior psychology technician. Abby Pratt and Naya Jacobson. And the tutorial was graciously sponsored by Peter Cook. Thanks, Peter. Before we get started, here's just a little housekeeping. So if you want snacks, there are snacks. If you need to take a drink of water, there's a fountain across the hall. Nearest bathrooms are in Ham. If you need to take care of yourself in any way during the presentation, it's kind of long, please take care of yourselves. Don't feel like you have to sit down through the whole thing. The only thing is just be respectful of the other attendees that are here. Try and take care of yourself quietly if you can. We'll also have designated time at the end of the presentation for questions. So please, if you can, hold your questions till the end, and we'll be happy to answer as many as we have time for. Also, just so you know, this meeting is recorded on Zoom, but none of you are in the camera, and they can't hear you because you're not speaking into the microphone. So don't worry about it. But I just had to tell you. Okay. What else? Just so you know, this is a large amount of information. We read so much science this semester, and we really tried to pull it down just to a couple points for each topic, but it's a lot that we're going to be throwing at you, and it's kind of a long presentation. There's no test. Don't worry about it. If you find something interesting, try and get excited about that, but if there's something that you don't want to pay attention to, you don't have to remember it. There will be more coming, so sit back and enjoy the ride. Let's dive in.
Okay, so talking about menstruation can feel unnecessary or uncomfortable. There's a lot of taboo surrounding menstruation that goes deeper than discomfort. A 2002 study was conducted with university students where a female research assistant would drop either a hair clip serving as a control group or a tampon for the experimental group, like Liz did just now, if you noticed. Results of the study found that those who witnessed the tampon drop group, as opposed to the hair drop group, gave poor evaluations of both the research assistant's competence at her job and overall likability. Because menstrual taboo is still largely present, and because it's been shown to affect the lives of those who menstruate, it is important that we continue to have public educational discourse about the science of the menstrual cycle.
This is not your middle of high sex ed. We're not going to split you up by gender. We'll have some rickety television thing and show you a weird video from the 1980s. But we are going to try and fill in some gaps that sex education probably has. Does anyone feel like they had adequate sex education growing up? Okay, as one kind of man, that's honestly better than I thought it would be, because sex ed is something that is battled over in legislature, not often informed by current research and understanding of bodily functions, and something that is vital to people's understanding, because everybody with the body deserves to understand how it works.
So Liz was just talking about the importance of sex ed, but it's also important to understand that research backs up sex ed being important. Research shows us that comprehensive sex education helps students become healthier and more well-adjusted adults, leads to lower STI rates, fewer unintended pregnancies, better self-esteem, healthier relationships, and many more benefits. And largely, sex ed gets a bad rap. There's a lot of controversies of sex education that interferes with learning about reproductive and anatomical functioning. There's this big avoidance of sex talks that often leads into a neglect of useful pubertal information on the hands of educators and carriers.
Right. Moving on to this great big slide, which might seem intimidating at first, but I will break it down for you. No worries. Okay, up here at the top, we have a list of little phases of the cycle. First, we have the menstrual phase, which is the shedding of the endometrial lining. So the endometrium builds up throughout the rest of the cycle, and it sheds during menstruation. That's what makes up your period. It's blood, it's tissue, etc. And after that phase, or sometimes people consider menstruation also to be a part of the follicular phase, during the follicular phase, There's a buildup of uterine lining, there's development of ovarian follicles, and we have some dominant hormones like follicle stimulating hormone, which tell the follicles to develop. Can you see the laser pointer, or am I wasting my time? Okay, you can see it, cool. All right, in the next phase is ovulation. The ovulatory phase is when the egg is actually released from its little egg sac of development. And when it is released, it becomes something called the corpus luteum, which means yellow body. And the corpus luteum is what the luteal phase is named for. The reason why is because this is important. It produces progesterone, which is one of the dominant hormones during the luteal phase of your cycle. So also up here, it's important to note, which you probably can't see the numbers. Sorry, they're super tiny. We can share the slides with you later if you want to look at the numbers. The hormones are plotted on different scales. So over here, LH, FSH, testosterone and progesterone are on this scale, and estrogen is on its own scale because it is higher concentration than the rest of the hormones going on in a typically cycling person with years. So there's lots of variation between individuals and between cycles. Also on this top graph, we have basal body temperature, which we'll get into the importance of later, but that's this little dashed line with the diamonds. And as you can see, there's a biphasic shift happening. During the first half-ish of the cycle, the temperatures are pretty low. During the second half of the cycle, the temperatures are relatively higher. The reason for that is because when the corpus luteum produces progesterone, it feeds back on the hypothalamus in the brain and tells your body to crank up the thermostat. Related to if your body was trying to support a recently implanted fetus, it's like an incubation mechanism. But even if you do not become pregnant, you'll still observe higher temperatures during the luteal phase because of that feedback. Moving on, so cervical position, which might not be something you've ever thought about. If you aren't aware, the cervix is the part of the uterus that protrudes into the vaginal canal. And across the course of one menstrual cycle, the cervical position changes a lot. It can be soft or firm, it can be low or high, and the cervical os, which is the opening, can be closed or open. So this charts an average or an example of what the cervix might be doing during the cycle. So as you can see, during the most fertile period, which is around ovulation, that cervix is high, soft, and open. During the non-fertile periods, the cervix is lower, more firm, and more closed. Also related to the cervix, which you might not have ever thought of before, is cervical mucus, which is something that the cervix uses for lubrication, and fertile quality cervical mucus is essential for fertilization. So without the presence of fertile quality cervical mucus, like outside of this window here, fertilization is a lot less likely. So when ovulation is happening, your body is making what's called egg white cervical mucus. Called that, because if you've ever cracked an egg, it's clear, it stretches, it's more watery relatively. And then during other parts of the cycle, these lines are for lotiony, creamy, or dry and sticky cervical discharge. Moving on, so we already talked a bit about the endometrium, but that is the uterine lining. It sheds during menstruation and it slowly builds up over the rest of the cycle. And then the ovarian cycle is happening at the same time, which we already talked about. But in the beginning of the ovarian cycle, there are actually several ova that develop slightly, and then one becomes the dominant egg, and the dominant egg is the one that gets released during ovulation. There we go. Broken down for you. Let's move on.
Okay, so taking a closer look at ovulation specifically, this year, 2024, is the first time anyone has ever recorded a live ovulation. So this is a mouse ovarian follicle, and we're watching the primary follicle expand, contract, the egg is ejected, ovulation occurs, and it leaves behind the corpus luteum. So I want you to again if you're interested. Once again, this isn't a mouse.
And it's live.
Live. So it looks like a little explosion, it's pretty intense.
Okay, next we are going to talk about endocrine systems. So you just heard a lot of stuff about hormones, but where do they come from? How are they regulated? Okay, so first of all, there's two basic drives of an organism, survival and reproduction. Everyone knows this. So endocrine systems help to regulate these essential processes. So we're going to talk about two endocrine systems, the HPG axis and the HPA axis. This stands for hypothalamus, pituitary, gonadal axis, or hypothalamus, pituitary, adrenal axis. So first, let's talk about the HPG axis. So as I was saying, it starts in the brain. So there's a lot of complicated brain parts that you don't need to worry about. But there's a part of the brain called the thalamus, which is basically the central relay station for all the sensory information in your brain. So you're taking in a lot of info from a lot of places, and the thalamus takes that all in and says, okay, where does this need to go? Below that is the hypothalamus. So the hypothalamus takes all this information you're getting, and it says, all right, I need to stimulate some hormone release. The hypothalamus then creates a neuropeptide called gonadotropin-releasing hormone, sends it to the pituitary gland. The pituitary gland is this funny little gland in your brain. Fun fact, the only hormone-producing gland in the body that's in the brain. So that's pretty cool. It's this funny little gland, and it's made of two lobes, anterior and posterior. So the hypothalamus sends GnRH to the anterior lobe of the pituitary gland. Then the pituitary gland, the posterior part, creates follicle stimulating hormone and luteinizing hormone. And it sends this out to the gonads. It does this by crossing the blood-brain barrier and sending FSH and LH through the bloodstream down all the way to the gonads. Gonads could be ovaries or testes, but in this case, we're talking about ovaries, although it's important to note that testes also produce all of these hormones too. So, we're in the gonads, or the ovaries. The ovaries then get stimulated by these hormones, and they produce mainly estrogen, progesterone, and testosterone, which are steroid hormones. And it's important to note that this is not a one-way street, but it's actually a loop, a negative feedback loop. And so what that means is that just as the brain communicates to the gonads and tells them to stimulate hormones, the hormone production that the gonads are doing talks back up to the brain and tells it how it needs to regulate the system. So I'm producing enough hormones, stop stimulating me, or there's not enough hormones down here, tell us to stimulate more. And so this system can be interrupted with certain methods that we'll talk about later, but that's essentially how it works. So that's the HPG axis. The HPA axis is very similar, except instead of going to gonads, it goes to the adrenal glands. So it starts hypothalamus to pituitary, but then the pituitary stimulates the adrenal glands, and the adrenal glands produce a lot of hormones, but some of the important ones, cortisol, epinephrine and norepinephrine, or colloquially known as adrenaline and noradrenaline. The adrenal glands also produce testosterone and estrogen and other steroid hormones that are you think would be only produced in the gonads. And so these two systems are survival and reproduction boiled down. And so this is important to understand because there is a deep connection between the brain and the hormonal cycle. And that's the basic breakdown of those endocrine systems.
So, like the cycles that the hormones are circulating in, but it's important that you understand that hormones are made by complex chemical reactions. Do not worry about this whole chart right here. The only thing I want you to worry about is understanding that this is a steroid hormone pathway. It starts with cholesterol. Cholesterol is made into things like progesterone with the action of enzymes, which are biochemical catalysts. From progesterone, the body can make testosterone, and from testosterone, we can make estradiol. So these things are not made in a vacuum. They are made through chemical pathways, and this is the main one that we'll be talking about today.
Okay, so hormones are produced in ways that endocrine glands like the pituitary, what I was talking. And then they travel through the body systems to impact biological processes at specific targets. So looking at these hormones and the ones we're looking at today, everybody has them, just in different concentrations. So within the sex or in looking at different sexes, like your average cis man has LH and FSH and estrogen, and your average cis woman is going to have testosterone. And both of these people are going to rely on them for proper bodily functioning.
Okay, so the first of the big five that we're zooming in on today is estrogen, which is primarily synthesized in the ovaries, as you might expect, but it's also produced to a certain degree in fat cells, in breasts, in bones, in the skin, in the brain, etc. So on the steroid hormone synthesis pathway that we looked at, the enzyme that converts androgens like testosterone to estrogen is called aromatase. You don't need to know that. But where there are high levels of that enzyme, there will be higher levels of production of that. As you can see on this chart, which is hard to tell because we cut off the part where you can see the little egg bursting out, but this is ovulation right around here. So just pre-ovulation, there is a really big peak in estrogen, which scientists used to think was important to cause the LH spike that follows it. We now think that maybe it's not causal, but estrogen still plays a significant role in the pre-ovulatory spike in reproductive behaviors. So that's important. Estrogen, apart from reproductive functions, it also mediates mitochondrial function, which, as we all know, is the power of the cell. Estrogen also increases the expression of antioxidants, so it's neuroprotective. It regulates hunger and fullness cues to a certain degree, and it influences brain function. So some researchers named Maki and Dumas, after reviewing a large body of estrogen research, they found that estrogen exerts its influence on cognitive behavioral processes by acting on both cholinergic and serotonergic systems. So those are two different kinds of neurotransmitters. It impacts hippocampal, so like memory related, and frontal, so like thinking big picture planning, executive function type stuff, particularly enhancing memory and memory retrieval. Also, in estrogen studies, it's important to know that we know way more than we used to. We still don't know all that much, and it is not simple to test estrogen effect in humans while doing so ethically, because it's hard to separate out one hormone from another in a human subject. So we rely a lot on rodent models when we're studying hormones like this. So through rodent models, we're able to intervene more. So researchers can, for instance, turn off a certain kind of estrogen receptor and leave the other kinds on. So we know through that kind of study that estrogen receptor alpha is associated with higher levels of aggression and increased HPA axis activation, while activation of a different kind of estrogen receptor called beta is associated with suppression of aggression and lower HPA activation. So because estrogen acts on both of those receptors, sometimes at the same time, it's not easy to say, oh, estrogen does this, it makes you less aggressive. Estrogen does this, it makes you more aggressive, because it does both. It's part of this complex behavioral patterning that we can't really discern down to this black and white because it's that. Interesting though, if both estrogen receptor alpha and beta are knocked out, a complete loss of sexual behavior is observed. So we know that estrogen is super important for reproductive. Next up, progesterone.
Okay, the next hormone, progesterone, is the primary hormone during the luteal phase. So this is produced by the corpus luteum, or that shriveled up yellow egg sac. And its main purpose is to thicken the endometrium, which is the same thing as that uterine lining for successful implantation of a blastocyst. Progesterone has notable metabolites, so it can turn into other things, including something known as allopregnanolone, which is commonly associated in literature with premenstrual stress. Additionally, progesterone can be converted into cortisol, which then feeds back into the body's stress response. So studies looking at allopregnanolone's role in PMS and PUBD have not found evidence of higher concentrations in symptomatic versus non-symptomatic individuals. So this means that if you take someone who's experiencing premenstrual distress and someone who isn't, and you take both of their blood, you're not going to find a difference in allopregnanolone levels. So the theories surrounding the hormone's role in negative emotionality surround receptor sensitivity rather than actual concentration. So maybe the receptors in the brain are more sensitive to that existing amount of love in the body. Now, there's also this distinction between natural progesterone, which is produced during pregnancy, and synthetic progesterone, like in a hormonal contraceptive. Now, natural progesterone, like in pregnancy, is not associated with negative emotionality or neuroticism, but those in synthetics, like hormonal contraceptives, are. Another theory surrounding receptors have explained this. So throughout pregnancy, your receptors for both progesterone and cortisol become less sensitive. So that could explain why taking a synthetic high amount of progesterone versus having a natural high amount could be different because of that receptor difference. Now, progesterone is blamed a lot for that like PMS, distasteful, hated luteal period, but there's some theories that argue that it's evolutionarily advantageous. So having that post-ovulation role that progesterone plays, where you're more receptive to negative emotionality, negative stimuli, possible threats, could serve as an extra layer of protection for a newly forming pregnancy.
So FSH and LH. So LH is luteinizing hormone and FSH is follicle stimulating. So FSH, the main role is follicle development, follicle stimulation, and LH plays a role in the actual ovulation as well as stimulating the corpus luteum to make primarily progesterone but also estrogen. FSH typically peaks mid-follicular phase, and LH peaks. We're not actually sure if it peaks right before ovulation, at the exact time of ovulation, or shortly after ovulation. But it's somewhere around the actual act of ovulation that LH is peaking. And consequently, the fertile window typically overlaps with the peak in LH to a high fidelity.
Okay, so bringing it back to production, gonadotropin releasing hormone, or the GnRH, which is produced by the pituitary gland, stimulates the production of LH and FSH. So it decides to produce either based on pulse frequency. So if it has a faster, pulse frequency and amplitude, it's going to favor LH secretion. If it's slower, it's going to favor FSH secretion. And together, LH and FSH coordinate the development and rupture of the follicle. And then once it ruptures, we have the corpus luteum, which then produces progesterone. So this is another example of a negative feedback where a lot of progesterone would then inhibit that LH production. So that could be how, like, if you're taking a hormonal contraceptive that is primarily progesterone, you're not going to operate.
Or you might be less likely.
Okay, and then the last of the big 5 hormones, don't worry, it's the last one, is testosterone. So, first of all, there's a lot of misinformation floating out in the ether about testosterone. I'm sure all of y'all have heard some crazy stuff online regarding testosterone and personhood, and I won't get into all that. But it's important to understand everyone has testosterone. Testosterone plays roles in everyone's bodies, and it's not this mythical, magical thing that a lot of pop science makes it out to be. It is important to the body, but so where does testosterone come from? As discussed earlier, it's produced mainly in the adrenal glands and the gonads. What does testosterone do in the bodies of people assigned female at birth? So it's not just a man hormone. in the female body, testosterone partly is converted into estrogen, but it also helps to regulate menstruation, aid contraception and pregnancy, minimize osteoporosis, stimulate hair growth, and many other things. As well, testosterone, as you can see here, it's this tiny little one down here because in the AFAB body it is a lower concentration, but it still has peaks and lower parts, but it's just harder to make out on this graph. So I will tell you about when the peaks happen. And the peaks happen coinciding with the pre-ovulatory period. So that's like right around here. And also during the menstrual period. So it's like right around here. And during these peaks, during the pre-ovulatory testosterone peak, high testosterone coincides with increased rating of physical condition and sexual interest. And during the menstrual high testosterone, it coincides with elevated stress perception. So testosterone is often overlooked when talking about menstrual signs because it fluctuates at a lower level than the other hormones, but that doesn't mean it's not important.
Okay, so stress and cortisol are phase sensitive. So in our follicular phase, we're gonna have a higher baseline cortisol level. So that graph on the right is looking at the duration of baseline cortisol level. And then during that luteal phase, that baseline cortisol is going to be lower, but we're going to have spikes. So if there's a stressful event, you're going to have a bigger spike and then down the hill with cortisol levels. So then in this picture on the left, we have the synthesis of cortisol. So you see that CRH, which is corticotropin releasing hormone, is a step. So CRH suppresses LH, pulse, and surge, which can delay ovulation, which is why maybe during the stressful month, your ovulation is delayed, maybe your cycle length is a little longer, your period is delayed. This is an example of the prioritization of that HPA survival axis over that HPG reproductive axis. Now, additionally, you can see next to this little placenta figure, there's also CRH. So under the brain and next to the placenta. So CRH is produced by the placenta during pregnancy. So cortisol levels throughout pregnancy continue to rise and rise. Again, we talked about that the receptor sensitivity is lessened. A theory of this is that it's prepping the body for like the intense act of labor.
Okay, and also like we've mentioned numerous times now, because the HPA and HPG axes are correlated with these two immediate drives of an organism, it makes sense that there are these many intricate and interlinked pathways where they can exert force on each other and kind of restrict the body's capability. So estrogen can have differing effects on cortisol reactivity based on the receptor and brain region that they bind to. So this is another mouse study. In mice, they found that estrogen receptor alpha increases HPA axis reactivity, while estrogen receptor beta decreases it. Also, testosterone has been found to decrease HPA activity as well, which is theorized to be because the testosterone can be converted directly to estradiol, and then the estradiol form that it's converted to is more active on the estrogen receptor beta. Kind of cool. So during the cycles when estrogen levels are lowest, the cortisol response to stress is reduced compared to when progesterone and estrogen levels are high. Okay, so we're moving on to a totally different section. You've learned some cycle basics. Now we're going to talk about hormones and transition.
Okay, so starting with menarche, which is a term for the onset of menstruation. So the average age at menarche is 12.4 years. However, throughout the past decade, that menarcheal age has been decreasing about 2 to 3 months every decade. But recent research is showing that it's starting to level out again. So for the past 100 years, people were getting younger and younger as they started menstruation, but we're starting to reach a new level. Now, it takes about 2 years for cycles to become regular. So you can see that menarcheal line and then the hormone concentrations that follow it. So that blue line, which is that luteal progesterone, you can see slowly trying to catch up and rise. So irregular cycles when we first start menstruating are caused by the immaturity of that HPG axis. So, for example, like this progesterone building up, if you have an insufficient amount of progesterone at first, you're not going to have a consistent thickening and therefore shedding of the endometrium. And then we have a second transition with this menopause. Okay, so menopause is probably more well known than menarche, but it happens to everyone that So menopause is the last menstruation, and an actual menopausal diagnosis can only be made 1 year after a menarche or lateral period, and that's like the real final
last period, but the process of menopause happens as early as your 30s, as seen on the graph. And this is less talked about and is actually kind of an understudied section of health. And a lot of people in their 30s going through the beginning stages of menopause are experiencing symptomology related to it and aren't sure how to cope with it and are told by their doctors that they're not menopausal yet. And so, that's all in your head. So, what is happening in ovaries during menopause? So, as you run out of eggs toward the later end of your life, because you're born with all the eggs you're going to have. So, toward the end of once you're like near your 30s, right, you have less and less eggs left in the stomach. And so, at each ovulatory period, your follicles are less and less because you have less and less eggs to ovulate. And so, as your ovarian function begins to decrease, we know from earlier that these follicles and this ovulation is what produces hormones like estrogen. And so with less ovarian function, you're producing less estrogen, and that's what creates the physical symptomology.
And the physical symptomology is pretty intense for some people. So 80% of females report menopausal symptomology negatively impacting their life. So looking at that premenopausal period, we see an increase in FSH, which is that yellow line, and reduced levels of estrogen, progesterone, and luteinizing hormone. So estrogen is becoming less and less, and it's rarely prompting that LH peak. So we're having anovulatory cycles, or cycles without ovulation. Now, hypoestrogenism, which is that lowering lack of estrogen, is going to continue to increase, and the HPG axis as a result is becoming less sensitive. Now, bringing it back to receptors, we have estrogen receptors in important areas in the brain, including the hippocampus, the prefrontal cortex, the amygdala, the thalamus, and the hypothalamus. And notably, these areas are important for emotionality and memory. So a lower sensitivity to estrogen is going to affect these areas that are receptors for it. Additionally, the interaction of estradiol with these receptors impacts the release and metabolic regulation of important neurotransmitters that you probably recognize, like dopamine and serotonin. So fluctuating and declining estrogen levels are going to cause disruptions in mood, disruptions in thermoregulation, so those like characteristic hot flashes of menopause, and interruptions in sleep, because unfortunately a lot of hot flashes happen in the middle of the night. Now, specific to dopamine, we're going to see an increased risk in dopaminergic degeneration, so like Parkinson's disease. And as for memory, we see an increased risk in neurodegeneration related to memory diseases like Alzheimer's. And this is for postmenopausal females as compared to males of the same age because of the way that the body is reacting to these hormonal changes.
Additional consequences of the menopausal transition because of that decrease of estrogen and progesterone. It's also associated with a generalized slowing down of metabolism because estrogen partially regulates mitochondrial function, and because estrogen is present in fat tissue, adipose tissue. So when estrogen levels drop, AFAB people generally experience an increase in weight and weight redistribution to different parts of the body that they might not have had before. So adipose homeostasis, so fat homeostasis, that cycle, also the regulation of sex-specific distribution of adipose tissue. So this adiponectin is a protein that helps to regulate glucose and insulin levels in fat. And so it's influenced by one of the estrogen receptors. So when estrogen acts on this, it helps to regulate that glucose insulin cycle. So when we have a decrease in estrogen, sometimes one of the menopausal symptoms people get is this development of insulin insensitivity or reactivity. Okay. And there are lots of different theories of menopausal management. Typically, your first line is your doctor might recommend things that are lifestyle changes like diet and physical exercise. But a lot of people find that their symptoms persist even with these kinds of baseline changes. So This is a really interesting study that was done in mice. I have to say it was done in mice, it was not done in humans, but that does not mean you can't have important takeaways from it. So this is comparing HRT, which is hormone replacement therapy, and TCM, traditional Chinese medicine. So there is this formula called Yin Hua Tang. I'm sorry if I mispronounced that. And it has been made for like 300 years. This formula has been used in traditional Chinese medicine for the regulation of menopausal symptoms. So in this study, the researchers tested its active ingredients using liquid chromatography mass spectrometry. I don't know if any of y'all took Orgo, but basically they ran it through a fancy machine and the machine said these are the compounds that are in this formula. So in the formula, actually, one of the active compounds is estrogen. So in addition to estrogen, they also found things like apigenin, camphorol, quercetin, genistin, tons of different things, like over 200 active compounds in this oral formula. It's made up of just 5 herbs. But in this study, they compared 3 different doses, a low dose, medium dose, and high dose of this traditional Chinese medicine formula to a modern day estrogen-based hormone replacement therapy supplement, and compared it to the control, so just like a normal mouse, and compared it to a mouse model of menopause. So the mouse model of menopause had the ovaries and uterus removed, and it was also stressed out by occasional removal of the water bottle from its tank. Like it wasn't actually going to get dehydrated, but it didn't let the water bottle to stress out. Sorry to the mice. Thank you to the mice. So in all of our test conditions, this is the mouse model plus the low, medium, high dose, and mouse model plus progenitor. So after they had given the mice these treatments, whatever treatment they were assigned to, they measured tissue quality of the vagina and the endometrium. They measured serum estrogen levels, behavioral outcomes like attack or explore behaviors, sleep quality measured by time to fall asleep and duration staying asleep, as well as body weight and organ. So I think the most interesting findings here are that in the endometrium, which is the lining of the uterine tissue, in a typical menopausal model, you're going to expect to see a thinning of this tissue because this tissue proliferates under the presence of estrogens and such. So as we can see, this model mouse, which did have the menopause condition, but it didn't have any medication, there's a significant thinning of the tissue. However, in our low, medium, and high dose, we can see at least some thickening, but the best results are in the medium dose of the herbal formula and the Progenova estrogen supplement, which are right about on par with our control condition where the mouse did not have the menopause condition. Same sort of thing observed with the vaginal tissue thickness. In the model, we expect to see a thinning of the tissue, and we do. And in both the Progenova and the medium dose, we see a really good thickening of that vaginal tissue. Another one is attack behaviors. So when you're irritable, you might attack. And so when they're like taking the water bottle out of the cage, sometimes the mice will start to attack the water bottle or the researcher's hand in the cage in general because like, hey, don't take my water, dude. I might attack you too. But anyway, when we see this model condition, there's a lot more attack behavior going on, and that is decreased under all 4 of our experimental conditions. The last one, which I find worthy of presentation to you today, is the serum estradiol levels, which, as you would expect, when you supplement with estrogen, you have more estrogen in the blood. But also, when you supplement with this herbal formula, you will also see a higher level of estrogen. So, because this was done in rodents, but it has also been used in humans in traditional Chinese medicine for over 300 years. So, more research is obviously always a good thing, but the big takeaway here is that there are multiple avenues of symptom management that are actually studied and can be helpful to people dealing with menopause. Okay, you guys have sat through like 45 minutes of this. I'm proud of you. We've got another topic. Okay,
So we're gonna talk about hormonal contraception. Well, actually, contraceptive methods. There are a lot of contraceptive methods. This means like methods to not get pregnant, right? There's a lot of different ones out there. And first, we're gonna talk about hormonal types of contraception. So this is a monotonic list of different types of hormonal contraception available to you on the market. So hormonal contraceptives are made with various forms and dosages of synthesized versions of hormone. So we talked about progesterone and estrogen. So hormonal contraceptives are made of like lab-made synthesized versions of these hormones. So that would be like ethinyl, estradiol, if any of you have that on your little box. And other synthesized hormonal types. So, first we're going to talk about the oral pill. So, oral contraceptives can be combined estrogen and progesterone. Some are only progesterone. Some are high dose, some are low dose. So you've got a lot of variation. And they require you to take a pill at the same time every day. And you do this for 3 weeks. Most of the time, you do this for 3 weeks of the active dose. And then as the 4th week, you take sugar pills so that you can have withdrawal relief. When we talked earlier about the endocrine systems, the HPG axis and all that, this is that thing I said could disrupt that system. Because when you have, when you're putting synthesized hormonal levels into the body, you are hijacking the loop that tells your brain how many hormones you're producing and how many hormones to keep producing or stop producing. So it pretty much shuts off your natural production of these hormones. So you're putting the synthesized versions in and you're not doing that cycle. And that's why these work as contraceptives, because then you're not, fertile. Okay, next, the implant. One implant you can buy is called Menstrual. This is only progesterone and it gets implanted into your arm, which is a little bit freaky to me. It's like a little metal rod, you implant it in your arm. And this releases a low dose of the progesterone for a period of up to 4 years. That's crazy science. You can also have a hormonal IUD. Now they have copper IUDs, which don't have hormones, but most IUDs can get hormonal. So hormonal IUDs have various dosages and progesterone. This is inserted into the uterus and it releases a low dose of progesterone for a period of 3 to 8 years. You can also get an injection like Depo-Provera. This is only progesterone. And this is injected into a muscle, and this is done by like a medical professional in an office. Like they get you a little syringe and they inject it into your thigh or something. And this injection happens once every 3 months. There's also the patch, which is like a patch that you put on your skin somewhere. This typically contains both estrogen and progesterone. And a new patch is placed on the skin every 3 weeks, and then you take it off for the 4th withdrawal week. That's kind of like how the oral contraceptives work, but instead of a pill, it's patch. And then finally, the ring, like Nuva ring, this contains both estrogen and progesterone, and it's inserted into the vagina, and you leave it there for 3 weeks, and then you take it out before the withdrawal week. Yeah. So that is hormonal contraception. The types that's available. So, as I was talking about earlier, these contraceptives work because they cause endocrine disruption with the introduction of synthetic ovarian hormones into the bloodstream. And so, as you're disrupting your endocrine system, like a really widespread level, there are a lot of impacts to your body that happen when you disrupt your endocrine system. But also, there's only really positive impacts of hormonal contraceptives being available. Many people take some form of hormonal contraceptive, and some people take it for the contraceptive purposes, but it can also be prescribed for a myriad of other purposes, like acne control or symptom management for some endocrine disorders we'll talk about later. And many people do take it for the contraceptive purpose, and that's a very important, powerful tool for reproductive autonomy. So it's important to understand why this exists and why they're important. But it's also just as important to understand that there may be some negative side effects to disrupting your endocrine systems in this way. And so negative side effects on the physiology, both physiology, you have like a long list of symptoms, you can get nauseous or gain weight or whatever, but there's also psychological impacts. Research shows that some of these impacts could be altered and potentially maladaptive emotional processing, alterations in neurophysiology, it's like your brain, both structurally and functionally, in brain areas associated with cognition and emotion, differences in adaptive social behaviors that we'll touch on in a minute, and also suicide risk. So there was a study done that compared suicide risk and attempts in those who take hormonal contraceptives and those who don't, and it found an absolute increase in suicide attempts for hormonal contraceptive users at 1,400 per 1 million person years. Person years is a weird measure, but that's like, if you have 100 person years, that's like 10 people or 10 years for one person over 100 years. You get the gist. So that's 1,400 per 1 million person years. So that's a large sample size. Risk attempt ratios between 1.61 and 3.08, depending on the age of the person who's taking the contraceptive and the type of method that they're using to take it. So these risk attempt ratios, we can understand them by, if the risk ratio is 1, that means hormonal contraceptive users and non-users have an even risk. And if it's anything above 1, that means that there's more risk for hormonal contraceptive users. So that was between 1.61 and 3.8 in both attempted suicide and suicide. So this is really serious, and medical professionals and people considering taking hormonal contraceptives need to be well versed in the risks associated with taking hormonal contraceptives so that they can weigh all the information available to them and make informed health decisions. This is not to say that hormonal contraceptives are not important and necessary, and it's not to say that they aren't immensely helpful for a lot of people. It's just important to understand the breadth of all the outcomes. Also, I talked about effect on adaptive social behaviors. So there was some research done by Kathleen Costo, who used to teach here, fun fact, that talked about hormonal contraceptives' effect on competitive behavior. Really cool research. And so this research found that hormonal contraceptive users did not show the same menstrual cycle-related fluctuations in self-perceived attractiveness and intersexual competition as naturally cycling people did. As well, hormonal contraceptive users had reduced status and achievement-oriented competitive motivation.
Okay, so competitive motivation, more recent research has kind of tried to dive in and explore that more. So one study looked at hormonal contraceptives' influence on perseverance. So it gave them solvable and unsolvable problems, either a math problem or a spot the difference image. And for like a math problem or a spot the difference image, they didn't clarify like, oh, there's 8 differences, or oh, you can actually solve or not solve math problems. That means that people would designate a certain amount of time to try and solve the math problem or try and think that they got the maximum amount of differences. Now, the study found that naturally cycling people spent longer on both types of problems and therefore had more correct answers because of it. So there was an increase in perseverance on these tests. Now, this could help explain why there is an increase in competitiveness, because that perseverance could possibly bridge that. But once again, this whole thing is the balance, because hormonal contraceptives are important tools to give yourself, the mode to be competitive in higher education or whatever paths that creates for you. Now we get to non-hormonal contraceptives.
Okay, cool. So talking about non-hormonal contraception, let's talk about what it is not. It is not based on calendar methods which use prior cycle data to predict future fertility. That is not safe. Don't do that. It is not based on apps where their algorithm of calculation is a mystery to you. Don't trust something if you don't know the algorithm that it's using to predict your fertility. Your life is way too important. Reliable pregnancy prevention is also not achieved by, do I feel fertile today? Without considering any specific factors that contribute to fertility. Also, many people of various religions use choose to use fertility awareness methods, you don't have to be religious to use a non-hormonal method. You don't have to be religious to use a fertility awareness method, even if it is popular among most populations of people. Also, it is not abstinence only. There are fertility awareness methods that allow you to have sex with people who produce sperm, and you still won't get pregnant if you use it right. It is also not limited to barrier methods like condoms. So there are different methods of fertility awareness. These are lots of things that it is not. Fertility awareness methods, reliable ones, rely on daily charting of typically multiple data points to understand when the fertile window occurs so fertilization can be avoided. So, what is it actually? Importantly, I'm gonna just give you this disclaimer right off the bat. This presentation will not give you enough information to follow a fertility awareness method. If you would like to follow a fertility awareness method, you will need to do some research outside of this presentation so that you can understand exactly what that entails and exactly what you have to do to follow the rules correctly and avoid pregnancy. While we're training, let me tell you a little bit about what it does entail so you have some idea if you're interested in it, or maybe you're just glad it exists, even if you're not going to use it. So different methods require a focus on various factors, things like the basal body temperature we talked about earlier. So that's your lowest temperature upon waking. People usually take their temperature first thing in the morning before they get out of bed around the same time every day. That relies on the understanding that after ovulation, the corpus luteum produces progesterone and you have the temperature spike. So you can observe that biphasic shift that tells you, okay, yeah, I'm ovulated. The next thing that can be observed, like we talked about earlier, is cervical position, cervical mucus, urinary hormones. So if you pee in a cup and stick a little test strip in it, those test strips, depending on what they are, can tell you your LH levels. And a little bit less commonly, they could also tell you about estrogen and progesterone. There's something called a beta monitor that's like, I don't know specific for what it is, but it does tell you more levels of hormones than just a test strip. Also, just like physical symptoms like either breast tenderness, ovulation pain, mood changes, all of these are data points that contribute to this overall picture understanding of where you are in your cycle. By charting a few cycles with the awareness of a lot of these different data points, patterns emerge that allow a greater understanding of current fertility. So different methods include the Billings method, which is cervical mucus only. Taking charge of your fertility relies on basal body temperature, cervical mucus, cervical position, and anything else you want to add. The Marquette method requires clear blue urine tests to track estrogen and LH levels. Sensiplan requires DBT, CM, CP, etc. So lots of different methods have different choices of variable that they track, and they also have rules to follow. Different methods have different rules about how to open that window and how to close it again. What means you're now in your fertile phase and what means you're out of it. So before we move on, some contraindications or some reasons why you might choose not to use a fertility awareness method as your primary form of contraception is if you are unwilling or unable to abstain or use a barrier method during sex involving sperm during your fertile window. Or if you are at risk for severe medical complications if you were to become pregnant. If you know that that's a risk factor for you, this might not be. Although they can be very reliable, we'll look at efficacy on the next slides. If you experience bleeding between menstrual periods that's difficult to distinguish from the period itself, it also might not be for you. But if that does not apply to you, maybe this could be something that allows you to escape from the hormonal contraceptive side effects if that's something that impacts you. Okay, so this is an example chart. And this is one person's chart from one single complete. So we can see at the top, actually, I don't know if you can see this. I'm going to tell you about it though. So at the top, there's cycle day. Then we have the basal body temperature, which is taken with multiple decimal places. So you're not just saying, oh, it was 97, and it was 98, we're going all the way to 98.16 with like a lot of specificity. We also see the phase count, so this person counts how many days they bled, how many days they had a follicular phase, and then how many days they had a luteal phase. In this section, this person also counts their LH ratio. So with a lot of the LH test strips, they don't give you like a concentration number. What they do give you, if you have a little rock on your phone, it'll give you like a dark line, that's your test line, like the test, there's like always that dark line of test condition, and then the control is the one that's always dark, and then the test is whatever is present in the sample. So that can be a very faint line, or it can be a very dark line. You can get an app on your phone that gives you a ratio. And so instead of just a qualitative, this line is lighter, this line is darker, it will give you a quantitative number that you can chart, which gives you something a little bit easily comparable day to day. Also, this person keeps a bleed record, so it looks like they have pretty heavy bleeding the first 2 days, and it's a little lighter, but there's a day of spotting, and then at the end of the cycle, there's spotting before the bleed starts. This person also charts cervical position, cervical mucus, and some notes about that. So different methods have different rules, and this person, we can't tell how they opened their fertile window, but we do see, you probably can't see this, I can see it, I'll tell you about it. At the top, they counted 1, 2, 3 tenths above the cover line before they closed the fertile window. So this concept of a cover line is basically taking a certain number of temperatures before the temperature shift. You add about 0.1 to add a little buffer, and then we count the temperatures above that cover line. So again, different methods have different rules about how to draw a cover line. But if you have a certain number of temperatures above the cover line, you can be fairly certain that your progesterone has risen, meaning, congratulations. Okay. Let's see. So each column is a day's entry. So one day, another day, we just add it up day by day by day. And doing this takes maybe 5 minutes a day. It's not actually that big of a obligation unless it's something that the person's accustomed to. But there is a lot of learning on the front end so that you can ensure that you're actually doing it. Okay. So efficacies. I'm very curious about this. Like, is this something that I can actually rely on if I chose to do it? I don't know if you can read that. That's okay. So this study from Denazi et al. It lumps together all fertility awareness methods, including calendar methods. That's important because, as we mentioned earlier, calendar methods are not a reliable form of contraception because they rely on past cycle data to predict future fertility. And there's a lot of variation, even within one individual, from cycle to cycle. So it's not safe to say, oh, we're related on day 14 last month, so I'm going to ovulate on the same day. You can ovulate many days differently from month to month. So very important that we're tracking something more reliable than just cycle. So with that caveat that this study includes the calendar method in their efficacy, even with that, the unintended pregnancy rate per 100 women for 13 cycles with the symptothermal method, which is what they're calling fertility awareness, is 1.61 at the top end to 0.43 for perfect use. So 0.43 all the way up to 1.61. Compare that to combined oral contraceptive pills. So a birth control pill with both an estrogen and a progesterone in it. That has a ratio of 0 to 2.18. So those are very comparable numbers. So that's 0.43 all the way up to 1.61 compared to 0 all the way up to 2.18. So and that's with typical use and perfect use. With perfect use, you obviously see a lower risk, and with typical use, you see what the numbers are that we're talking about here is a Pearl Index score, which is a statistical estimation of the number of unintended pregnancies per 100 person years, we talked about earlier. So if it's 100 people over 1 year of use or 10 people over 10 years of use, that's still one. And a lower Pearl index represents a lower risk of pregnancy. So to combine oral contraceptives, even when we're including calendar methods. So that's pretty good. This next slide, this next study actually breaks down the different fertility awareness methods by methods. You can see which ones have studies behind them that show them to have a greater efficacy. So the best ones on this, among the tested methods, and there actually are more methods of fertility awareness that are not on this chart, but the best ones that were tested are the census plan double check and the market method. Also, this chart is actually interactive, so if you find it on the host website, you can click on different methods, see what variables they ask you to track, and I'll actually go directly to that method's website, so you can see in detail the information method by method. So this is the BMJ, kindness, everything, fertility awareness method thing. If you want the link, you can ask me this after and I'll send it to you. The important thing to note here about these comparable, you can't do that at all, can you? Okay, well, there's this big red circle here. That's one of the fertility awareness methods with a high efficacy. This is another one. These three lines are long-acting reversible contraceptives like IUDs and the arm implant and Explanon, because those are like 99.9% effective. And these two lines are sterilization. So you really can't get higher birth control efficacy than sterilization. So these are extremely high efficacy rates. This line is the combined oral contraceptive pill. So this little dot is perfect use, that little dot is typical use. We can see that actually both of these methods have a higher efficacy for even typical use than the combined oral contraceptive pill. Some of these other methods are not as accurate with their typical use, which is why it's important you know what method you're choosing so you can follow the rules in a way that actually results in what you want it to result in. Another cool thing which I didn't mention in the slides, but if you're doing this sort of self-tackling, this fertility awareness method, if at some point you decide you actually do want to get pregnant, you're going to know exactly when the best time is to conceive a child, and it probably won't take you as much time and energy and stress as it might take someone with 0 cycle awareness, because you're really looking for what it is. So that's cool. It can be used as a contraceptive, or a lot of people use this sort of thing for the purposes of procreation, if that's what they're aiming for. Okay. One more section, 2 more sections. Second to last section, this is menstrual and ovarian disorders, and we're gonna try and speed run it because y'all have been amazing with your attention. Couple menstrual and ovarian disorders, just so you know what's up. Okay, first we're gonna talk about PMDD. I'm saying this really heavy, but a lot of these are not. Okay, PMDD, premenstrual dysphoric disorder. PMDD is a chronic disorder, and it is characterized by severe emotional and physical symptoms in the week or 2 before menstruation. So you probably have heard of PMS. Raise your hand if you've heard of PMS. Raise your hand if you've experienced PMS. Yep. So PMS, or premenstrual syndrome, is symptomology before your period. So that's cramps, mood swings, headaches, any myriad of things. PMS is experienced by 70 to 90% of AFAB people. That's people so PMDD is not PMS. PMDD has a lot of the same types of symptomology as PMS, like cramping, mood swings, myriads of physical and emotional symptoms. But PMDD is specifically at a level of severity that deeply impacts your ability to go about your life and your daily functions, whether that be making it to class, making it to work, your relationships with people. And so PMDD, the diagnostic criteria for PMDD is only met by about 5 to 8% of people assigned female at birth. So what causes PMDD? This is an interesting question because scientists are not even sure what causes PMDD. This is because female health is a grossly understudied field. It's a big issue.
it needs a lot more research done into it. This is starting to change, but these are important things to understand because a lot of people deal with them. 5 to 8% looks like a small number, but it's like millions of people when you think about the population. So, although we don't know exactly what causes it, there's science-backed hypotheses about what causes it. So, the leading hypothesis is that PMDD stems from maladaptive neural sensitivity to ovarian steroid hormone fluctuations. So, to break that down for you, PMDD is not a hormonal imbalance. So if you test the blood of someone with PMDD and someone without PMDD, you're not going to find different hormone levels. But what you may find is the person with PMDD has more sensitive receptors to those hormones. And a lot of hormone receptors are in the brain. And so there is a big link to the brain in PMDD. The structure of the brain even. So research has found evidence of trait-like cortical characteristics in certain regions of the brain of individuals who have PMDD. So this image here, if you're not a neuroscientist, you probably don't know what gyrification index and cortical complexity are. Essentially, your gyrification is how like bumpy and foldy your brain is. The more bumpy and foldy your brain is, the more available cortex you have, the more available neurons you have. And so in certain brain regions, highlighted in color, individuals who have PMDD have lower gyrification in their brain structure in specific brain regions. That's not to say that you're dumber if you have PMDD. That's not what's implied here at all, but that there are structural differences. So PMDD is not all in your head. It's not something you make up, but it is linked to measurable brain alterations.
Okay, the second disorder is endometriosis, which is the presence of endometrium-like tissue outside of the uterus. So this could be in your ovaries, in your abdominal cavity, or even outside of your abdominal cavity, which could be like the chest or even the brain. So this affects 10% of females during reproductive years. Once again, large number. However, almost 60% of those diagnosed will have to see over 3 clinicians over a span of 7 years with symptoms to receive a diagnosis. Part of this is the barrier for diagnosis is pretty tough. You need a pelvic ultrasound. So it takes some time and it takes apparently on average over 3 doctors. Now, the common symptomology of endometriosis is chronic pelvic pain, dysmenorrhea, which is pain during menstruation, infertility, fatigue, and painful sex. So, how is this treated? With often surgery and post-operative hormonal contraceptive use. However, some studies have shown that pelvic physiotherapy, so like massaging painful areas that are affected, has been found to be helpful in alleviating pain symptoms for some people. Now, once again, the cause is still largely unknown because it is understudied. So we have some theories. The first one is retrograde menstruation of menstrual stem cells. Now, the issue with this being the only theory is that everybody does a little bit of retrograde menstruation, which is when instead of going down and out vaginal cavity, it goes up and kind of like backwards into the ovaries. So everyone does a little bit of this. But there's a theory that this could be a possible cause. Now, another theory is inflammation, but this is like a chicken egg situation. Inflammation coexists with endometriosis, but is it the cause or the effect? And lastly, maladaptive tissue repair. So, another theory of the cause of endometriosis is that maybe damaged tissue has been repaired improperly, leaving behind some type of scar tissue, like uterine tissue. Okay, and our last disorder is PCOS, or polycystic ovarian syndrome. Now, PCOS is the most common AFib endocrinopathy, impacting 6 to 20% of people worldwide. Now, notably, the word cyst is in PCOS. Cysts are not weird. Cysts are normal and they develop into follicles. The issue with PCOS is that we have these like maladaptive cysts. You can see in a normal ovary, we have some of these cysts. One of these is going to be like the primary follicle that's going to undergo ovulation. And once it actually properly does that, it's going to leave behind those corpus luteum egg sacs. Now, compared to a polycystic ovary, we have like this overcrowding of cyst follicles that don't want to ovulate. So the issue with PCOS is that they are underdeveloped. Now, this has to do with the impairment of the multiple steps of the feedback loop. So, like, the feedback loop is this, the pattern of GnRH secretion, which we've talked about a couple of times, which then impacts levels of LH and FSH secreted by the pituitary, which then impacts the function of cells in the ovaries, so like development, and then steroid hormone synthesis. So like notably, if you are ovulating and then you have the cortisodium, you're producing progesterone, but then this whole cycle also impacts like estrogen and testosterone, which then feed back into GnRH and how it's going to perform. So the cause of PCOS is a disruption in the cycle, and as a result, altered neuroendocrine hormone patterns and altered follicular functioning. So a lack of FSH, which is characteristic of PCOS, is going to lead to excess LH, low FSH, and is going to affect the way that follicles behave. So normally in a healthy individual, LH and FSH are going to coordinate that development and rupture. While in PCOS, you're going to have that high LH, low FSH affecting a proper follicle development. Now, this lack of FSH also means that hormones like testosterone aren't converted into estrogens like they usually would be. So this goes back to that steroidogenesis pathway. Hormones turn into other hormones. This is going to impact that. And then, like I said, these excess androgens feed back into that GnRH secretion, promoting more LH production, which then continues this cycle of imbalance. Now, because of this difficulty ovulating, there's that lack of progesterone, which is why often in PCOS you can sometimes see, the symptomology of infertility. Okay, so next we're going to talk about no longer disorders, but gender diverse experiences of and menstruation. Okay, this is our last topic, you guys. You're doing such a good job. I know this is a lot of science getting thrown at you. But, okay, gender diverse experiences of hormones and menstruation. We talk a lot about this stuff, and it's important to understand how different groups of people are affected by this type of stuff. So, before we get into it, it's important to understand sex and gender are not the same thing, and neither are binary. So, let's get into it. Sex. What is sex? Sex is biological characteristics. That's your chromosomes, that's your sex organs and genitalia, that's hormone levels. Now, a lot of times this can look like it might be kind of binary. This is where you get male, female, assigned at birth type of situation. But a lot of people have a lot of different mixes of all these different factors. And this is truly not a binary. Next, gender. This is not what's in your pants. This is how you identify. This is a personal thing. This is your concept of your own self. Now, gender roles are something that happens in society. This is stereotypes for behaviors. This is societal expectations. And gender presentation is how someone chooses to present out in the world. So this is your physical appearance. This is choices about your clothes, your hair. None of these may be congruent. It varies a lot. There's a lot of different variation. So now that you have that background.
Okay, so this is something that is wild to me. How many of you know a redheaded person? Wow, okay, look around for a second. Keep your hands up and look around. That's almost everyone. Yeah, almost all of us know redheaded people. Redheaded people make up 1 to 2, redheaded people make up 1 to 2% of the global population. Now, I'm not saying redheaded people are more or less likely to be intersex, but it's the same percent of people who are intersex. So 1 to 2% of the global population are intersex, and a different, probably overlapping in some way, 1 to 2% of the global population are redheads. You probably know intersex people. You have probably spoken with them. They might be your friends. They might not even know they're intersex, or they might know they're intersex. But it's important for us to recognize that because science has known and continues to know that sex is not a binary, it's really important that we include these people in conversations about things like menstruation and also just in larger context of everything. So it's more common than you might think. Also, because we didn't have a working definition yet, intersex conditions, or also known as differences in sexual development, are things that result in internal anatomical, external anatomical, or genetic differences in sexual characteristics. Some of them are associated with specific physical features or comorbid medical conditions, but others have more subtle effects that might never be discovered or might be discovered sort of incidentally by accident on a medical examination for something else. So intersex conditions can arise from a number of atypical factors in development, like chromosome differences, additions, mutations, or unexpected crossovers. They can also result from abnormally high exposure or low exposure to steroid hormone levels, either during gestation or after the child is born. If it's after the person is born, then it would be due to the cells that would normally produce those hormones maybe don't produce them, or maybe they don't respond to one of the factors, even the whole big chain of things that could be happening. Intersex conditions can also occur due to influence of enzyme levels, steroid hormone receptor deficits, etc. Many different causes. And so many intersex infants are subjected to quote unquote normalizing genital surgery as infants that are either masculinizing or feminizing towards the opposite ends of this spectrum that we see here. But these surgeries lack evidence that they help with anything at all, and they can actually negatively impact intersex people's lives down the line, not only in terms of functionality, but also in terms of you might not identify with the gender you are assigned at birth. And what if they already did a surgery on you when you were an infant, when you didn't even know who you were? So lots of questionable stuff happening there. Also, some intersex conditions combined with this socially defined sex binary can result in the presence or absence of menstruation when it's expected to be the opposite. So imagine if you were raised as a man your whole life, you identified as a man, and then one day you started menstruating. What the heck is it? Or if you were raised female, you identified as a woman, but you never got your period. And all the people around you are getting your period. They're talking about it. It's like this big thing that's happening in your life. And you feel kind of like that. In either scenario, that would feel really like isolating and scary and like your parents hadn't warned you about it, maybe. Like, that's a lot to deal with. So that exact phenomenon, this men who menstruate and women who don't kind of thing, was studied in an interview-based pilot study in Nigeria. So a pilot study basically just means like a small study that gathers evidence before we do a larger, more robust study. So this was an interview-based study with 13 participants at a particular gender clinic in Nigeria. And the agreement, the findings of this study were that a lack of robust sexual education made every single person's experience worse. They wanted increased access to information about menstruation in general, puberty, etc., as well as their specific intersex conditions, and all of those things would have helped them to cope or request their desired care sooner. There's also agreement that parents need more information as well, not just the people with the intersex conditions, and that children should be informed early about the things that their bodies are likely to experience as they grow, so they don't come as like this. Yeah, it's not as binary as we thought. There are over 40 known intersex conditions, 40 different sexes. Okay, and we're going to talk about two because they're okay. I should have included this, but I did not. So if you have like a bell curve, and you have another bell curve, there's this area in the middle where they overlap, and it's not actually a binary. There's actually like a whole lot of overlap in the middle between these bell curves. That makes it not binary, but we know it's spectrum. It also doesn't have to be a linear spectrum. It can be a three-dimensional spectrum of all sorts of factors going on all over the place. So the main idea here is that more awareness is needed of intersex conditions as a normal aspect of human diversity. And moving on to hormonal replacement.
Okay, HRT. We talked about HRT earlier in this presentation in the context of menopausal symptom management. So HRT is hormonal replacement therapy. So you can see that in like cis women dealing with menopause, taking replacement therapy to help with their symptoms. A lot of different people take HRT for different reasons. A lot of those reasons are gender-based. And it's important healthcare for everyone. So for these people taking specifically testosterone-based hormone replacement therapy, so this is like for people assigned female birth who are taking testosterone, how does this affect your uterus, your ovaries, and your cycle? So on average, these people are going to experience amenorrhea between 8 to 12 months. Amenorrhea is when you don't get your period anymore. This is an average. There are a lot of varied experiences within this. Some people never stop getting their period. It happens at different timelines, but it happens within 12 months after starting testosterone. So administration of testosterone inhibits follicular genesis. So that's when your follicle develops and makes the egg come out, and that's the whole ovulation thing. So this isn't to say that HRT is contraception, because it is not. You can very much still get pregnant, but it does lower your follicle levels, and so as a result, it lowers estrogen. And so on testosterone, you're going to reach equivalent to postmenopausal levels of estrogen after about 6 months on testosterone. Testosterone also increases your basal hematocrit levels, so that's number of blood cells in your bloodstream. And long-term testosterone administration during reproductive age induces low proliferative active endometrium with some hypertrophic myometrial changes. What does that mean? Okay, we talked about the endometrium, that's the uterine lining. Okay, the endometrium, the uterine lining. So a proliferative active endometrium is like the normally cycling thickening of the endometrium, and it's active and it's dynamic throughout the cycle. So on testosterone administration, you're going to see less of that. Your endometrium is not going to be thickened up as much. It's not going to be as active. That's why a lot of times you're not going to be menstruating anymore. In addition to hypertrophic myometrial changes, which is like the muscle part of the uterine lining, can experience some like fibroid type situations where the muscle part gets really kind of thick, fibroidy. Oh, interesting. Let's get back at the mic. It's okay. Anyway, the takeaway here is that HRT is useful for gender affirming care in many scenarios, and people who take it should have access to comprehensive information about the way it biologically functions.
Okay, finally closing it out. Thank you for patience. Okay, so bringing it back to social attitudes towards menstruation and personal attitudes and why we're here, why does anyone care, or why should anyone care? Okay. I conducted a study this year examining menstrual community in meme making and found some interesting themes. So yes, these graphs are from my Excel. Okay, so you can't super read them, but the most common theme was menstruation as a normal biological event. The second most common theme was menstruation as an inconvenience. And type for third, we have menstruation as an indication of health, menstruation as an experience of pain and suffering, and menstruation as a mode for meaning making. Now, I also looked at like the chart of description. So the most common was a neutral description that contained like a duality of like, oh, menstruation is awful but awesome. And the least common description was just positive. So additionally, I found that me making about menstruation and community during menstruation were both correlated with more negative descriptions of menstruation. Now, this must seem confusing, but it's actually in line with a social theory called menstrual moaning. So what does this mean? In private community, we complain about things we cannot in public community. So a good example of this is like in middle school, I know I have memories of like being in like a 7th grade math class and just having like for some of my first times, really painful menstruation or like, like an issue and not being able to vocalize it or do anything about it out of embarrassment because of the taboo, right? But then the first thing I did when I found like in the locker room or in the restroom or I had a group of my friends who also experienced menstruation would complain and talk about, oh, it hurt so bad or oh, it was so, I lived through it, it was horrible and all of these things. And what taboo does is it eliminates, spaces to have these broader conversation, and it just gives us these pockets to vent. Which often leads to the separation of our bodies and their functioning. So like, if you went to your friends and you told them like, I am ugly, if you're like, no, 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 no. But if you go to your friends and you're like, my body's functioning is awful, everyone agrees. So there's this separation there. It's less clear that complaining about menstruation is complaining about your body's functioning because we use a different language for it. We're not using words like I or me, we're using words like it. So it's less clear that we're critiquing our bodies because we create that distance and we make menstruation into this external entity that at times is like attacking us. So a lot of times we have this dialogue of like, my period sucks, it is torturing me, it is disgusting, it is embarrassing. When really what is being said is my body's functioning sucks, my body's functioning is torturing me, my body's functioning is disgusting, my body's functioning is embarrassing, and that's what we're told. So, you're not wrong for that, but it's what exists in our society. So we can really use more opportunities to talk about this taboo subject of menstruation without only having space to complain. And additionally, having larger conversations about menstruation ultimately helps to dismantle that taboo that so often interferes with our overall understanding of what's going on with menstruation, which most of us didn't really learn in sex ed, and appreciation for the menstrual cycle, because ultimately that's our body's functioning. This is really, really important because the past research by Chrysler et al. Has shown that there are correlations between having positive understandings of menstruation or positive attitudes towards your menstrual cycle and having a more positive attitude towards your own body and body image. Now, this is also important for institutional support as well.
Yeah, so like Abby introduced, not only is menstrual attitude an issue individually, but it's also an institutional issue. So, okay, so let me tell you about the Campus Cup project. This was a study done where hundreds of universities across the US partnered with this study that gave out free menstrual cups to anyone who goes to school at those universities. A menstrual cup, if you don't know, it's a way, it's like you insert it and collects your menstrual blood. It's like a pack of tampons, it's not bad. So they gave out free menstrual cups and they gave out information on them. And what the study also did, in addition to just giving it out, is it collected information on the effect of doing that at institution. And so what this study found was that institutional support for menstruation increased people's personal attitudes toward menstruation. So if you were a student at that school and you said, wow, my university cares about my menstruation, they're giving me free menstrual cups. This is something they deliberately did. My university cares about menstruation and is talking about it. My university supports me in that way. Those people had more positive outlooks on their own menstruation. And as Abby said, more positive outlooks on menstruation also correlates to how you view your own body more broadly. So institutional support is also a really important conversation when we're talking about social attitudes toward menstruation. And how this relates to us. So notably, New College of Florida used to receive both outside funding and donations for free menstrual products to be available on campus. However, large-scale distribution of these menstrual supplies is no longer currently occurring on campus. And so you have to wonder how this lack of institutional support affects all of our own personal attitudes about ourselves, and also the broader social context for menstrual attitudes. Okay. We've talked about so many things. You guys have sat through and listened really well. So to remind you guys some of the things we talked about, we're just going to sum it up into the important takeaways. Okay. Yeah. Okay. Comprehensive sex ed is so important. It's important for healthy outcomes and the understanding of our own bodies. Many biological factors fluctuate across the cycle. So observing these patterns gives us a robust and useful understanding of our body's functioning. Endocrine systems communicate in a brain-body feedback cycle in which hormone receptors convey complex information, a lot of different things.
Many hormones play an important role in menstruation. So this includes like normally quote unquote man hormones, testosterone plays a role, so does progesterone, estrogen, and LH and FSH. Hormones fluctuate both monthly and throughout the lifetime. So we looked at those graphs of like, oh, the way that hormone fluctuations change, like the follicular, ovulation, luteal, menstruation, but also we have these hormonal changes from menarche to menopause. And there are many methods of contraception, and people should be aware of their efficacy and also their side effects.
Also, menstrual endocrinopathy impacts both the brain and the body. It's not something that's in your head. Old-timey science used to say that people had a migrating uterus if they had any sort of problem and happened to be a woman. Now we know not only are there actual causes, they occur both in the brain and the body. Also, more awareness is needed of intersex conditions as an aspect of normal human diversity. And hormone replacement therapy is an important tool for not only transgender things, but also for gender affirming care for people. Finally, social and personal attitudes towards menstruation impact a variety of outcomes on structural and personal health. So after this talk, our hope is that we've filled in some gaps where previous sex and menstrual education has left you, and hopefully giving you information that empowers you going forward. If you're curious to learn more, these are 3 of our recommended readings. Personally, Taking Charge of Your Fertility by Tony Wechsler, which is an excellent, accessibly written guide on one particular method of fertility awareness.
Dr. Gunter's Blood, it's really good. It came out this year. It's basically like a deep dive into menstruation, anything menstrual related. It's also really accessible, but while also giving you like dipping your feet into the science. So if you want to know more about the science, maybe you're not like for behavioral endocrinology, this is a great pick. And then the Calgary Handbook of Critical Menstrual Studies. This is free through our library's website. You can get it online. And it's this huge textbook that's like a collection of essays and articles and literature, and it's just really cool, and it gives you more of like a sociological or a psychological perspective on menstruation. So it's super cool. It's on our library's website. Check it out. And these are all of our sources for this presentation. If you want to access them, let us know. And then notably, the illustrations not cited are originals by Liz and Naya. So thank you to them. And again, thanks so much for your time. We know that this was a lot, and your questions.
Also, you feel free to leave now. Thank you so much for being here. I know it's final week, but yeah, we'll take questions now. I saw Bo's hand first.